Bonjour tout le monde. Hello, everyone. Welcome to today's online event featuring two knowledgeable speakers who will be speaking about characterizing Canada's refugee health system. Before we begin today's event, we would like to begin with an acknowledgement that N4 is hosted at CHEO, which is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples and their valuable past and present contributions to this land. My name is Mariah, and I am a project coordinator on the N4 team. I will be hosting today's webinar. My co-host is Andrew Tomeyer. Andrew will be monitoring the question and answer box and chat box today. And I'm now very pleased to introduce to you today's presenters. And presenters, I am just going to kindly ask that you turn on your video as I introduce you. So our first presenter today is Dr. Gabriel Fabreau. Dr. Fabreau is an assistant professor in the Department of Medicine and Community Health Sciences and an active member of the O'Brien Institute for Public Health at the University of Calgary. He is the co-founder and co-lead of Refugee Health YYC, which serves as a research, innovation, and education platform at the University of Calgary. Clinically, he continues to provide care as both an embedded internal medicine specialist at the Mosaic Refugee Health Clinic and as an inpatient physician at the Peter Lougheed Center. Dr. Fabreau completed an MPH in clinical effectiveness at the Harvard School of Public Health and an academic fellowship in general internal medicine at the Brigham and Women's Hospital, Harvard Medical School in Boston, Massachusetts. His research interests include health services, socially vulnerable populations, complex chronic diseases, and the clinical and public health research with a focus on the health of recently arrived refugees in Canada. Dr. Fabreau is committed to working towards health equity for newcomers through community engaged efforts. Welcome, Dr. Fabreau. We understand you're coming from a clinical service. Thank you so much for joining us and being here today. And our next presenter today is Nesma El Shazli. Nesma is a policy analyst at the University of Calgary's Refugee Health YYC program, where she coordinates a study to characterize Canada's refugee healthcare system. She holds a Master of Arts in Conflict, Security, and Development from King's College, London, and has extensive experience as a project officer at the United Nations Office on Drugs and Crime, where she coordinated a project to prevent and combat human trafficking and migrant smuggling in the Middle East and North Africa. Welcome, Nesma. Thank you so much for joining us today. Today's session is being recorded and will be uploaded to our N4 platform as soon as it becomes available. And should today we experience any technical difficulties, we will inform you with details for an alternate makeup webinar. And before we begin today's webinar, I do want to take a moment to introduce you to our platform features and let you know how you can engage and participate today. Throughout today's session, we invite you to write your questions using the question and answer window. We know that sometimes many of you might have the same question or be interested in a particular response. So today you do have the option of upvoting questions that you are interested in hearing the answer to. And we will definitely prioritize the questions towards the top of the question and answer box to pose to our speakers today first. And our speakers today have no conflicts of interest to declare. And with that said, I am going to hand the virtual podium over to Nesma and Dr. Fabreau.
Perfect. Thanks so much for having us. And The kind introductions. I'm sorry, I'm on clinical service in the hospital, and it's still quite busy, so I'm running around. So I will. I'm just going to introduce and give a little bit of a backstory on this study and the goals and what we're trying to do. And then Nesma really has been doing most of the work, almost all of it, in the last year, and doing a wonderful job. And so part of what we'd like to do is present some of the preliminary data that we have to show the refugee health system in Canada. Next slide. I don't know if you have an overview slide. Yep, I study refugee health, so I never have any disclosures. And this is our agenda. I'll just give you a little bit of background on the study. We'll show you some of our findings, and then we will save lots of time for Q&A. So, and a thank you to the 1,000 partners that we have in the country. So this study started about 3 years ago, pre-COVID, if you can remember that far back. And it really came out of a pilot study we did in Alberta during the Syrian Refugee Initiative, which at the time was the largest refugee resettlement program in Canada since the late 70s, when Canada took about 70,000 refugees from Indochina, Vietnam, Laos, Cambodia in the late 70s and early 80s over a 2-year period. Now it seems commonplace, but at the time it was a very large influx. And so we did a study in Calgary, focused on the local health system and how the health system adapted to be able to accommodate a rapid influx of, I think we saw about 2,500 Syrian refugees in that first year, and then many more subsequent to that. We took that study and the learnings from it, and with partners across the country, we have a very strong clinical network of refugee health providers and refugee clinics in the country. We took that and expanded the idea that we really, despite well over 100 years of history, if you go back almost 200 years of history of resettling refugees in Canada, we really don't have it written down anywhere. What is the structure, the processes, or the infrastructure that we use to care for refugees? It really is fundamental knowledge in order to be able to respond quickly to national programs of resettlement, such as the Syrian refugee influx. Since we started the study, much has happened. We've had the Yazidi refugees come to Canada. We're a smaller cohort, but very high needs, very, very traumatized, that arrive very acutely. And then, as everyone knows, we're in the middle of 2 more, so double concurrent refugee influxes, one with the Afghan refugees and with the war in Ukraine, many Ukrainian refugees as well. So the findings hopefully are useful. The goal of the study was to understand what were the existing care models and structures. So as everyone knows, likely in Canada, we call it the Canadian healthcare system, but really we have 13 separate systems that are similar as its provincial jurisdiction, but not quite the same. And so we really don't have one health system. And one of the problems with that in the refugee health world is that there really is this overlap of jurisdiction. So federal jurisdiction is resettlement and immigration, supports for all the social determinants of health, which are absolutely critical to the well-being and healthy resettlement of refugees. And then healthcare delivery and public health are in the domain of the provinces. And so how they interact is unknown. What we were hoping to understand is the structures between primary healthcare, which is the foundation as outpatient medicine for refugees, its interactions with public health, and it's also its interactions with the federally funded resettlement agencies and the federal government. And we adapted some models from health services and global health research to really try to study the health system's readiness to be able to manage a large influx of complex refugees with high health needs, oftentimes in a short period of time. What were the adaptations that each province or each sub-jurisdiction employ, and then use those findings to inform best practice across the country to learn from each other, as is the goal of research. And then two, also to put together for the first time an atlas, what we would call the Refugee Healthcare Atlas, which is the goal is to try to put this up on a living website and map so that healthcare infrastructure is publicly available for the public and for the resettlement agencies, et cetera, to know where to send refugees when they need healthcare. All right, next slide. Yes. So our hypothesis is pretty obvious. It's going to be very, very heterogeneous across the country. And I will pass it over to Nesma, who'll tell you how we've gone about doing things.
So I'm just going to skip back to the beginning and start with some background. Sorry about that. So as Gabe had mentioned, our objectives today are to raise awareness about our study, which aims to characterize Canada's refugee healthcare system. We're also going to describe different clinical care models across Canada based on preliminary findings of our study, and to try to understand the adaptations that have been made to accommodate rapid refugee influxes. And also we'd love to connect with refugee service providers through this webinar. So I'm sure everyone in this webinar is quite well aware of the fact that we are in a global displacement crisis. 82.4 million have been forcibly displaced due to conflict, persecution, human rights violations and violence. 26.4 million refugees across the world, 42% of whom are under the age of 18. There are 48 million internally displaced persons and 4.1 million asylum seekers. Syria, Venezuela, Afghanistan, South Sudan, and Myanmar account for 2/3 of the world's refugees and asylum seekers. Specific to our study, the main refugee crisis that we have faced in Canada started back in 2011 with Syria. So in the wake of the Arab Spring in 2011, protests erupted across Syria with people calling for democracy and the removal of President Bashar al-Assad, who quashed the uprisings with brute force. Syria became embroiled in a violent civil war that resulted in weak governance and shattered social services and institutions. Syria also became vulnerable to terrorist groups such as ISIS. The Syrian civil war gave rise to what is now known as the largest humanitarian emergency of our era. 95% of Syrians lacked access to adequate healthcare, 70% lacked access to clean water, and 50% of children lacked access to schooling. As a result, 6.7 million Syrians were internally displaced and 6.6 million were forced to flee the country in search of safety and security. More recently, on August 15th, 2021, the Taliban took over Afghanistan and they imposed drastic human rights violations. Afghanistan's Hazara Shia community faced targeted attacks and forced evictions. Women and girls' rights were rolled back by policies that curtailed their access to employment and education and restricted their rights to peaceful assembly. The Taliban also restricted free speech by cracking down on the media and detaining journalists. Almost 70% of Afghan media outlets closed down, and those remaining continue to operate under threat and self-censoring. Millions of Afghans suffered severe food insecurity due to lost income, cash shortages, and rising food costs. 3.5 million Afghans are internally displaced and 2.6 million are refugees. UNHCR predicts that the number of refugees will continue to rise as the situation continues to deteriorate. Even more recently, with Russia's brutal invasion of Ukraine in February of 2022, this inflicted yet another humanitarian crisis, forcing 7.7 million Ukrainians into internal displacement and almost 6.1 million to flee the country. As the invasion continues and more Ukrainians are forced to escape, the situation is set to become Europe's largest refugee crisis this century. As a global leader in refugee resettlement, Canada rapidly resettled 39,650 Syrian refugees between November 4th, 2015 and December 31st, 2016, with a total of almost 64,000 being resettled between November 2015 and April 2019. Canada has also committed to resettle at least 40,000 Afghan refugees through the ongoing Afghan Refugee Resettlement Program. 13,000 Afghans have thus far arrived in Canada. Between March 17th and May 4th of 2022, Canada also approved visas for 91,500 Ukrainian refugees under the Canada-Ukraine Emergency Travel Authorization. A total of 204,000 applications have been submitted within this same period. Refugees have complex health needs prior to their departure and during their migration. Pre-departure, refugees have complex health needs that result from the very same causal factors that force them to become refugees, as well as immediate life-threatening risks. Conflict also instigates long-term health risks from poor sanitation and food insecurity. During migration, refugees are also at risk for a variety of health problems because of travel through unsafe, unsanitary, and poorly resourced settings. This exposes them to physical and psychological dangers. The problem doesn't end once refugees make it to Canada. In some cases, refugees lack access to affordable health services upon arrival. In most cases, they face many barriers and find it difficult to visit health providers, get medicine and medical supplies, lab tests, and other essential health services due to distance, language, policy, or financial barriers. Treatment for ongoing conditions, including non-communicable diseases and malnutrition, is often interrupted. In many cases, refugees have to live with serious injuries for a while before they are able to access the appropriate health services. In response, community practitioners across Canada developed specialized refugee health models with various levels of provincial support to address the sudden and rapid influxes of refugees with unique health needs. However, there is no comprehensive description of Canada's refugee healthcare system. Our study, titled Characterizing Canada's Refugee Healthcare System Amidst a Global Migration Crisis, is a national study that aims to understand and characterize existing structures and care models of primary care, public health, settlement, and other healthcare facilities across Canada that provide care to refugees and claimants. This study is being implemented by the University of Calgary in collaboration with the Canadian Refugee Health Network and for IRCC and many other refugee health partners across Canada. The study is funded by the Canadian Institutes of Health Research. I believe Gabe already went through the study objectives, so I'm going to skip over this slide. So through this study, we studied the structures, processes, services, and adaptations of refugee health systems across Canada. We applied a multidimensional environmental scanning methodology through focused questionnaires to Canadian health and settlement facilities across 55 jurisdictions that received 50 or more refugees from November 2015 to present. So far, a total of 151 organizations have participated in our study. The breakdown is as follows: 44 primary care clinics, 91 settlement agencies, 9 public health offices, and 7 other healthcare organizations. Obviously, we haven't been doing as well with public health due to the COVID-19 pandemic. Public health practitioners are overwhelmed, and it's been quite difficult for them to find time to participate in the study. Primary care clinics from each of Canada's 10 provinces and 28 of the 55 jurisdictions have thus far participated in our study. Settlement agencies from 10 provinces and 1 territory and 57 jurisdictions have thus far participated in the study. Gabe had also mentioned our Refugee Health System Atlas, which is one of the main objectives of our study. So I'm going to show you a short video of our online health system atlas. It will be available on our Refugee Health YYC website. So it's publicly available. And I think the video will show it all. But as you can see here, it's color coded. So you can see by the colors, red is for settlement agencies, blue are primary care clinics, green are other healthcare organizations, and purple are public health. So when you click on each marking on the map, you'll see the name, the category, and the contact information of each clinic. So according to the degree of consent provided, the atlas displays each organization's location and contact information. So far, we have 110 entries. These are 32 primary care clinics, 4 public health offices, 4 other healthcare organizations, and 70 settlement agencies across Canada. You can zoom in to see the specific cities and streets. You can zoom out for a more summarized look of Canada. Today, we're going to be presenting the preliminary findings of the questionnaires we deployed to dedicated and non-dedicated refugee-serving primary care facilities. We performed descriptive analyses of survey responses on 4 measures: services available, established processes, financial, knowledge and human resources, and readiness to receive sudden influxes of refugees. So this is just a pie chart that shows the different categories of clinics that responded to our survey. So we see that we have 47.4% dedicated refugee clinics, 28.9% clinics that regularly care for refugees and or claimants, but not solely dedicated to refugee care, 10.5% general community practices with some refugee health experience, and 13.2% dedicated free care clinics that provide care to anyone, irrespective of immigration status or healthcare coverage. We also looked at the estimated annual refugee and claimant population received at each clinic since 2018. There was a wide range of estimated refugee and claimant patients, as you can see. We also looked at systems for activation, coordination, command and control of operations in the event of a sudden refugee influx. 41.7% of clinics that responded to the survey said that they had a system in place for this. Similarly, 55.9% of clinics have a formal transition process for refugees and claimant patients for other, to transfer them to other primary care facilities for long-term care. 43.2% of all clinics have on-site specialists. Of these, 50% are dedicated refugee clinics and 36.8% of We also looked at use of the Canadian Collaboration for Refugee and Immigrant Health evidence-based preventive care checklist. So 58.3% of all clinics use this refugee healthcare checklist. Stratified, 55.6% of dedicated refugee clinics use this checklist, and 61.1% of non-dedicated clinics use it. With regards to language services, 100% of respondents use some form of interpretation or language services. The majority use phone interpreter services, in-person professional interpreters, and primary care providers who speak other languages. Some clinics also rely on volunteer interpreters, as well as family members to interpret, phone apps or other web-based translation tools, and other services. (61.1% avail community health workers, peer support workers, or peer navigator services for their patients. We also looked at clinics that were expecting to receive Afghan refugee patients. 23 clinics expressed that they expect to receive Afghan refugee patients. So 82.4% of dedicated clinics expected to receive Afghan patients, and 52.9% of non-dedicated clinics expected to receive Afghan patients. Of these 23 clinics, only 59.4% felt prepared to address their needs. We also asked clinics if they had direct communication with IRCC. 77.4% of clinics don't have direct communication with IRCC about the expected numbers and timelines of refugee arrivals. In terms of opportunities to continue our research, we also looked at qualitative data that was provided through the surveys. 14 dedicated refugee clinics expressed interest in participating in focus groups and interviews, while 11 non-dedicated clinics also expressed interest. Here are some quotes from dedicated refugee clinics. We've noticed that dedicated refugee clinics highlighted a lot of the challenges that they felt were pertaining to refugee care, namely competition for funding, COVID-19, making it difficult to coordinate with public health services, limited or no mechanisms to support care for uninsured migrants, and limited awareness about Afghan cultures and experiences. Here are some quotes from non-dedicated clinics. There was a variety, but some clinics did mention limited awareness of existing tools and guidelines. Our concluding remarks based on our preliminary findings show that while there is a wide range of refugee care models across provinces, there is relative consistency in refugee care processes. Despite these processes, clinics feel unprepared to receive rapid influxes of refugees. This suggests an immediate need to improve preparation through the integration of provincial health policies into federal resettlement initiatives.
Wonderful. That was so fascinating. Thank you so much, Nesma and Dr. Fabreau, for walking us through some of your preliminary findings. It sounds like that atlas as well is a really great resource for healthcare providers and settlement practitioners. I'm wondering, is the survey still open and can organizations still participate?
Yes, of course. Our study is open until the end of June. So we would love for everyone to participate. So we can actually circulate the link after this webinar, and we welcome everyone's participation.
Wonderful. Okay, and we will definitely circulate that to those who are on the webinar and who registered for the webinar today. And I'm going to just turn over to some of our questions. I know, Dr. Fabreau, that you were answering them live during the webinar. So maybe I'll just provide the opportunity to elaborate on some of your responses that you've provided. So the first one was around your dissemination plan for this research. So you mentioned that those working in the health and settlement sector can access the atlas. Just wanted to draw everyone's attention that those links are provided by Dr. Fabreau in the answered section of the Q&A report. How else do you plan to disseminate these really great results and this data that you've been collecting?
Yeah, thanks. So I did post, and maybe Nesma, you can repost the links both in English and French to the site on our Refugee Health YYC site, but it also has a link to register for the survey. Just echoing what Nesma said, it's been a 3-year slog because of COVID, but we really do need to wrap up our data collection. And so we have about 3 weeks left. And what we've learned is that the best way to get data collection is through word of mouth and with friends and connections. And of course, we have lots of friends in the refugee world, but we don't know everyone. So if whoever's on the webinar, if you have friends in clinics or you're interested, please, both in English and in French, please send out to your friends, clinic partners, resettlement agency partners, public health partners. That's one. And then second, our dissemination plan is it's interesting, we're reporting as we're collecting data, which is new, and it's a bit novel compared to traditional research, but we are going to have providers and can decide whether or not they want their data to be publicly available on the atlases as we build them. And so we routinely update the atlas monthly as we collect more data. So that is available on our website. And again, same link. And then we're going to, do the traditional scientific presentation. So a webinar such as this, we're presenting at NARC, and then we'll be writing up traditional scientific manuscripts. And then after that, we're probably going to work on, our plans are to work on reporting back to government with IRCC as a sponsor. Really important for the government to have a clear idea of where our refugee health clinics are, and so we can work and improve our integration communication. We're probably going to send back prelim or packages of results to everyone that has participated, so that everybody who has participated can have access to aggregated results. And we'll probably, everyone likes their own data. So one of the plans I have, or that we have, is to individualize it. So have people, their specific clinic or resettlement agency, we can highlight. Everything will be anonymized, but for each, we will give everybody their code for who they are so they can compare themselves to the rest of the country. And then we're open to suggestions. I think knowledge translation in science is really, really important. And I think, years of work, if it only gets reported in scientific conferences and manuscripts, it doesn't get to where it needs to get. So we're very open to suggestions around how better to disseminate the information. And the hope is, a lot of what N4 does is integrating resettlement with health and the community and society. And so I think we all know that the better we do that, the better care and well-being is for newcomers in this country.
Absolutely. Thank you so much for that response. And our next question is, how can healthcare providers educate themselves about supporting refugees, especially those who don't see many refugees or work necessarily in a refugee clinic?
Yeah, again, great question. We put together, again, on our website, we put together a pile of resources. One of our clinicians at the Mosaic Refugee Health Clinic, Dr. Mongeau, is an MSF hero, put together a wonderful resource that really summarizes up-to-date clinical information and guidelines across a lot of the conditions that are very common in refugee health, and also a lot of the guidelines we put together. The CMAG guidelines written by Dr. Potty and a lot of our team members in the Canadian Refugee Health Network were published in 2011 now, but a lot of good resources are there. And then there are others, so like caring for newcomers, kids new to Canada. All the links are there, so there's external links to a lot of other agencies and resources. Another really good resource is CAMH, so Canadian Mental Health Association did a really good job of putting together webinars for clinicians. It doesn't have to be physicians, but anyone that's in the caring, that are in the caring professions around the mental health conditions and management of such that are common to newcomers. So there's a lot of resources, and again, you know, we're just one program, but if people have good resources that they want to forward to us, maybe Nesma, you can put up our Refugee Health YYC website or email address. We'd be happy to continue to collect and update our resources. The hope was to build that section out for clinicians specifically for this reason.
Wonderful. Thank you. And it's very clear that your data collection process targeted service providers in particular. Do you have plans to connect with refugees that are newly arrived in Canada looking for care? Are there any plans within your study or research in the future or presently to connect with the service users?
Again, excellent question. And yeah, the answer is yes, of course, it's critical. And we need to talk to the patients. And so in our pilot study during the Syrian refugee program, we actually cut it in half. We did providers and we did patients. And so, you know, research, we have to take a stepped approach. So while we're doing this is the scaled out version of the providers study. We're currently, we're funded and we're piloting a small study in Calgary focused on creating a patient, we have focused on working with our patient advisory committee and creating a youth patient advisory committee to do exactly that, and have the patients direct our research, direct our care, and be deeply embedded as participants. And then our hope is to do similar to this. Once we've piloted it and we've learned, the hope is to scale out a second step nationally through CRHN and our partners, similar to this study, and hopefully this time without a pandemic in the middle.
Great, thank you. And there's a question here around in some of your slides, you had refugees from Ukraine. And so the question or the commenter is saying, I've heard from those from Ukraine that they're not being considered by definition in Canada as refugees, but rather displaced. I've also seen evacuees being used as a term. So how has that affected your data collection process? And do you have any further comments on that?
Yeah, that is it is a fraught political landmine field. And so by the definition, so I'm a refugee health physician researcher, so they are refugees by the definition as written in the 1951 Refugee Convention by the United Nations. They are fleeing war. The reason that sometimes refugees or asylum seekers can be labeled other terms, such as migrants is often used in Europe or in the US, is once they are called refugees, the governments that have and countries that have signed on to the international agreement are thus liable to provide the protections and safety and services to refugees and asylum claimants as laid out in that convention. And so one way governments sometimes try to avoid, I'll just be blunt, I think sometimes governments try to avoid these obligations. They can do so by giving them a different term. Now, in Canada, there is a different program for the Ukrainian refugees. So they're called evacuees, and different provinces are calling them different things. Essentially, they are refugees, but they are the first large group. They have a separate program. It's the CAUET and colleagues and I have written about this, hopefully will be published soon, that can outline some of the differences. The differences are small, but the basic premise is that every province has signed on to give healthcare services to Ukrainians that are arriving. And then there are services provided, they're just a bit different. And then the resettlement services are, I think, more integrated in the community. And I can't really speak to what the resettlement services are because I don't know them in detail, but they are all up on the IRCC website. If you just go Google IRCC and Ukraine, the CAUET program and its details are there, and they are moving, so they're changing. So even last week there was a new announcement for cash transfers to Ukrainians. The basic premise is currently Ukrainian refugees are being provided 3-year visas, similar to what they did in Germany with Syrian refugees, with the opportunity to stay and apply for permanent residency in the future. This was also done with Kosovar refugees in the 90s, so not brand new, but adapting as things go.
Nesma, you have your hand up. Go ahead.
Yes, sorry. Yeah, so just to build on what Gabe was saying, it is just a legal term, but I think the key point to remember is that they will still have the same complex health needs that refugees have. So whether you call them refugees, evacuees, permanent residents, immigrants, that's just all politics. But the health needs will be the same.
Great. Well, thank you both for that response. And the next question here is, in your opinion, with more and more immigration, refugee, and evacuee arrivals due to an increase in global crises, what can be done to better prepare the Canadian settlement and healthcare sectors or the infrastructure for the high volume of arrivals?
Maybe Nesma, do you want to take a stab at that first?
Yeah, so I think where there's a will, there's a way, and there is a will. And as we can see from, for example, little things can be done, such as our refugee health system atlas, sort of already encourages coordination between settlement and health, and that's the most important thing. We have already seen this sort of coordination in the past with past refugee influxes, but it's been very organic and more responsive, not proactive. And I think everyone is in agreement that a more proactive approach is needed. The fact that IRCC is also a collaborator of this study and is recognizing the need for better coordination between health and settlement services, I think that will also help encourage moving forward in that regard.
Yep, I agree with Nesma. The thing that we have learned is integration. So it is a bit of an idiosyncrasy of the Canadian systems that we have a confederation where we have jurisdictional overlap, municipal, provincial, and federal, and the better we coordinate, so municipally delivered services and agencies that coordinate with provincial health systems and that coordinate with federal ministries, I think the better we can do that. And I think the piece that Canada could be and should be proud of is that we invented the privately sponsored refugee program, and it's been really, really successful. It's been exported now to other countries. And so I think, as we're seeing with Ukrainian refugees currently, we have a huge Ukrainian diaspora, and they arrived over multiple waves of refugees from Europe, starting in the 19th century. And the Ukrainian community and the Canadian community at large, the more civil society is invited to participate, the better and more welcomed refugees do. And I think we have so as Nesma said, we've done that organically, and we did that with the Syrian refugee program as well. And so I think things that can help, and what the foundation of this study is just a first step to try to first understand where things are, and then hopefully try to build better bridges that can add some system and some process that can rapidly be ramped up and down to adapt to large influxes of refugees as needed.
Thank you both for that fulsome response. And there is a question coming in from a social worker in BC who works at a primary care site. And they have noted that their biggest problem is getting in touch with IRCC or obtaining any updates on a patient's situation or questions that they may have. And it looks like one of your slides that you shared from your data mentioned that the majority of healthcare workers or clients do not speak to IRCC directly. So do you have any recommendations for this social worker or for other healthcare providers out there for how to get through to IRCC as if when they have questions related to their client or their patient?
I don't actually. I don't know. Yeah, I don't. I have a hard time navigating the different branches of the ministry and who to talk to and who does what. So I think some relationships have been formed over time, over the years, working with different people during the different programs. And again, it's not a great process, but it's through those relationships over time. I think the best thing that we've learned in Calgary is that we have a really strong resettlement partner, CCIS, that's been in business for 25 years and one of the largest in the country. And so and there are others in Calgary, and that those resettlement agency partners are funded directly through IRCC and communicate directly to IRCC. And it was through our resettlement agency partners that during the various programs that we've participated in, that at least in Calgary, we made all of our connections with IRCC. So I guess that's just personal experience, but I think the best, there is no real direct line from healthcare to we found to the federal ministry for the reasons previously stated. But I think if you go through your resettlement agencies in your jurisdiction, I think that's oftentimes they have direct lines of communication.
Yes, and to that commenter or person posing that question, I do want to just also draw your attention on, if you sign up to become a member of N4, we have developed a member directory. And one of the goals was to support those working in healthcare, at clinics, at community health centers, to connect directly with folks in the settlement sector within their respective jurisdictions. So if you're not already a member, if there's anyone else, there is that tool on the N4 platform that might be able to help you. And then I also encourage anyone who's on the call that might be from the settlement sector, there is an option to comment on a question that's been asked. So maybe you can offer some support there. And the next question I have for you both is just around your research. So you're collecting this data. It sounds like you're wrapping it up. What are the next steps for your research, and what other research needs to be done on this in this area?
Maybe Nesma, do you want to go first?
Well, I do. So we are hoping to, once we wrap up this study, to then sort of have a follow-up study that creates sort of focus groups and interviews with primary care, settlement, and public health providers, so that we can further have an in-depth discussion on concrete solutions to improve refugee healthcare across Canada. And I'm not sure, Gabe, if you want to add anything.
Yeah, there's a ton of work to be done. So this is really just a foundational first step to, we have to understand what the system is and how it works and where everyone is and the pieces that link it together before we can start working on adaptations. One of the things that are really important is some of those qualitative pieces. So people that have answered the survey, we asked them, one of the final questions is if they'd be willing to be interviewed for qualitative research. Quantitative research gives you a broad overview and gives you some numbers and medians, but it's in that qualitative research with key experts across the country where I think we'll get a deeper understanding of what are the issues that are, like all things in Canada, we're a huge country, so some things are going to be jurisdictionally dependent of where you live, but there's a lot of general there's a lot of needs and suggestions and adaptations that are probably broadly generalizable. And so I think it's in, our next two steps are those. Speak with those that are willing to be interviewed to give us their expert opinions on what needs to be done. And then the second, as I mentioned previously, is critical, is talking with patients. So piloting our patient advisory committee to actually lead, to give us their priorities, and then similarly give us their priorities and then lead our research and embed patients within our research, and then hopefully scale that.
Great, lots more to come. That's wonderful to hear. And from the data that you collected, did anything surprise you, or did you uncover any findings that you weren't expecting?
No, I think so far our preliminary findings do confirm our hypothesis. And so there is marked variety. I think maybe the thing I was most surprised about was some clinics adding like comments at the end of the survey that they didn't know about the Canadian Refugee Healthcare Checklist. And I'm a newcomer to Canada, so this is all pretty new to me. I'm learning through implementing the study. But I do see a big need for some sort of formalized training or guidelines that can sort of be disseminated nationwide in these circumstances, whereby non-dedicated refugee clinics or organizations that don't necessarily work with refugees on a day-to-day basis can have direct and easy access to these resources, because the resources are available, they're just not well known, I feel.
Thanks, Nesma. And do you have anything to add, Dr. Verbro?
I guess it's very prelim. We only have, this is a snippet of just the providers data that Nesma showed. So we actually haven't been able to go through it all. We have a ton more data to go through. One of the things that surprised me actually is we've always, in the clinician community, we've always talked about the refugee clinic network, and we generally know where many of the refugee clinics are in the country through this. We have a very active clinical network. What surprised me is that some of our longest serving refugee clinics, when asked if they consider themselves a dedicated refugee clinic, said no. And so there is really and one of the things Dr. Vanessa Reddit pointed out the other day, or Vanessa Wright from Toronto, they both point out that there's a spectrum of providers. So some are just exclusively only see refugees, and then there's this, like, some clinics see 90% refugees, but also see some undocumented migrants and other people. And then there's just this spectrum. It's not really a black and white. So I think that's really interesting. And the way that people perceive their own clinics, I think is really important too, and helps to understand what is the gamut of how refugee healthcare is provided in the country.
Absolutely. Thank you both so much. And it's really been a pleasure to host this webinar with you and hear more about your study findings. And do you have any final key messages or remarks for the audience today before we wrap up?
I would just say, if anyone here hasn't yet participated in our study, please sign up, register today and complete it, because we really value your input. And the more data we get, the more we can learn and the more change we can impact. So please do. Thanks.
Yes, and tell your friends, because they don't know who we are, but friends listen to friends. So if you've done it and you have friends at a clinic that does see some refugees or any, maybe they're just seeing Ukrainian refugees arriving now, please invite them, forward them the link if you can. That'd be really helpful.
Great, wonderful. Well, thank you both again. And as I mentioned earlier, we will be sharing that to the email to everyone who's registered today. So I think you've said it well. Just everyone who's on the call, just please share that. And thank you so much to everyone for your participation. We had an excellent dialogue, lots of great questions from the audience. If you did miss any part of today's presentation or would like to watch the session again, we will post the recording on the N4 platform within the next week. And we've also curated some resources related to today's webinar topic. We also will be sure to include the link to the atlas that Dr. Fabreau and Nesma shared. And if you haven't yet, please do sign up to newcomernavigation.ca for all of our resources and to access our learning opportunities, including the recordings of this webinar. And following today's session, you will be invited to complete a very short survey to share your feedback with N4. These surveys do help us to continuously improve, and we sincerely appreciate the time that you take to complete them. You're welcome to join us again, of course, for upcoming events. Our next webinar is on June 22nd on Indigenous relations in Canada, addressing issues in moving towards a shared future. And finally, we also have a mobile app. So please do feel free to check this out on the Apple Store or on your Android device. And thanks again for joining us, everyone. We hope you can join us again at a future N4 event. Stay safe and be well.